you for attending this month's Ocean Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Anna Bloom of Oregon Health and Science University as she presents on the association between a mother's cervical cancer screening and their child's HPV vaccination status. Anna Bloom is a fifth-year MD-MPH student at Oregon Health and Science University. In medical school, she found a passion for primary care and is particularly interested in the intersection of public health and family medicine. As the founder and co-chair of the Family Medicine Research Forum, Anna is dedicated to fostering collaboration and guidance among medical students and researchers. She has established a platform for the meaningful exchange of ideas and insights that contribute to the advancement of primary care research. Anna hopes to work in academic medicine and participate in epidemiologic research pertaining to maternal and child health and preventive health. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 40 to 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Anna Bloom for the association between a mother's cervical cancer screening and their child's HPV vaccination status. Anna, the floor is yours.
Awesome, thank you. Hello, everyone. Let me just go ahead and share my screen. So, there we go. Can you all see this and hear me?
Looks great.
Great. Awesome. So I have no disclosures to report or competing interests aside from that this research was funded through a grant that is mentioned here. And before I dive in, I wanted to give kind of some context to both myself and my positionality. I'm, as William mentioned, a fifth-year MD-MPH student applying into family medicine. And I have performed cervical cancer screenings or pap smears and administered HPV vaccines to patients in the clinic. And I recognize that these experiences have placed me in a position of authority, allowing me to conduct sensitive exams and engage in intimate conversations about reproductive health. I also recognize the power and social influence associated with being a future medical doctor, and I'm dedicated to employing my position to advocate for health equity and justice. I also just want to acknowledge my immense privilege I hold as a cisgender white woman when it comes to matters of reproductive health and medicine. And having personally undergone cervical cancer screenings and HPV vaccinations as an individual with a cervix, I recognize the fortunate circumstances in which I was raised. I was raised in a very educated community with unhindered access to care and health insurance and health literacy and readily available primary care physicians. And I'm acutely aware that individuals of color and those living in poverty and those lacking health insurance lack the same resources. So some brief background on just human papillomavirus. It is a virus that is the most commonly sexually transmitted infection in the United States. And once infected, most people are able to clear the virus within about 2 years. But some variants of HPV can cause cancers, and if the body is unable to clear the virus, this increases the risk for precancerous lesions. So HPV causes almost all cervical cancer, as well as some types of anal, vulvar, vaginal, penile, and mouth cancers. But cervical cancer is the most common HPV-associated cancer. And then the HPV vaccine was actually approved in 2006 and is able to protect against variants of HPV that cause these cancers. And it has decreased the incidence of cervical cancer by almost 10% annually. And it is pretty incredible because it's really the only vaccine that we currently have that's been shown to prevent cancer. So the CDC recommends receiving the first dose of the HPV vaccine between ages 11 and 12, but can be started as early as age 9. And notably, this is for both male and female children. And then the second dose is given about 6 to 12 months later. Unfortunately, though, only about 2/3 of US adolescents have started the vaccine series, and even fewer have completed the series. And this rate is significantly lower than vaccines recommended for the same age groups. So, for example, national coverage for Tdap or tetanus, diphtheria, et cetera, is 89%, and then MMR, measles, mumps, rubella, is about 90%. And so there's also some significant disparities that exist in HPV vaccination. Vaccination rates are much lower in those living in rural areas, those who are uninsured, those who do not receive routine health care, and who have low incomes, as well as racial and ethnic minorities, specifically Asian, Black, and Hispanic women. Notably, HPV vaccinations are higher among women compared to men. And considering that this is a relatively new vaccine, there are also a lot of different social perceptions of this vaccine because it is associated with both a sexually transmitted infection as well as a cancer. So I think the theme that I've noted in these disparities is that access to care and being able to go to preventative appointments would be much more difficult for populations of people that are mentioned here. And so in our study, we were trying to think about how we might account for these barriers to care. So the goal of our project was to think about how we might improve HPV vaccination rates among adolescents. And after a thorough literature review, we found that maternal health care visits are positively associated with their child's visits, and that mothers who got the HPV vaccine were almost 3.5 times more likely to report that their child received the HPV vaccine. So we knew that maternal preventive behaviors might influence their adolescents' behaviors. Okay. And then just some quick more background, again, into cervical cancer prevention. There is also a secondary prevention strategy for cervical cancer, which is detecting precancerous lesions using a pap test, where cells are collected from a person's cervix and examined with microscopy. And these screenings are recommended for all persons with a cervix beginning at age 21. So we thought about how these behaviors might be related, and our research question became, are maternal cervical cancer screening associated with their child completing the HPV vaccination series? We also wanted to think about how this association might be different based on if the child identified as male or female, as historically HPV vaccination rates have been lower in adolescent males. And then we also wanted to think about the systemic barriers that affect people seeking preventative care, including insurance, income, access, et cetera. And so we ended up using a composite index called the Social Deprivation Index to see how this might modify our association of interest. And I'll dive into this more in just a moment. So first, we decided to perform a cross-sectional analysis, and our data source was an existing cohort of children linked to at least one parent using the following algorithm. And we used EHR data to identify children and linked parents, both seen in an Ocean Network CHC. This included 17 different states and 393 different clinics. And then we also wanted to limit our guarantor field or emergency contact field indicating mother to link the child with a mother. And then we continue to randomly select a child with greater than one ambulatory visit. And then we used CPT codes from the EHR data to identify parent preventative care from the Advanced Clinical Research Network. And we limited our analysis again to children with a linked mother. And again, this data was from the Advanced or Accelerating Data Value across a National Community Health Center Clinical Research Network. And then we also chose to look at community health centers from OCHAN because they serve patients that are more likely to face barriers to preventative care, as well as HPV vaccination and cervical cancer screenings. So I'm sure as many of you know, community health centers serve nearly 28 million patients nationwide, 8 million of which are children, serving anyone regardless of insurance status or ability to pay. And then most patients are uninsured or publicly insured. About 46% are on Medicaid. And then about 58% are members of racial and ethnic minority groups. And then about 68% have incomes below the federal poverty line. And then the social deprivation index is a composite measure of neighborhood level deprivation. It includes the proportion of single parent families, poverty, percent with less than a high school diploma, non-employed folks, and no car ownership. And it was actually developed using the American Community Survey and is a part of the Community Vital Signs data set. And an SDI score has a unitless range from 0 to 100. And so a higher score of SDI indicates more area level deprivation. And an SDI has also been shown to be associated with healthcare access and health outcomes. There's a positive relationship between SDI and mortality, low birth weight, infant mortality, and diabetes that persists after controlling for other measures of healthcare access. So we linked patient level EHR data and neighborhood level data at the census tract level using this data set based on the address that was noted in the child's EHR. And we assigned an SDI to each mother-child pair in the cohort and created SDI quartiles in order to examine whether the quartile of SDI modified the relationship between a mother's cervical cancer screening status and the child's HPV vaccination status. And SDI quartiles were based on the distribution of SDI scores in our sample. So an SDI 1 represents the least deprived neighborhoods at the census tract level, and an SDI category 4 represents neighborhoods with the most deprivation. So for our analysis, the primary exposure was maternal completion of cervical cancer screening during the child study period. And we used generalized estimating equations to estimate the odds of a child having completed the 2-dose HPV vaccine series. And we had 3 different models, one where we used social deprivation index and child sex as covariates, and one with SDI stratification, and one where we stratified by both SDI and child sex. And then we also had several different child and maternal covariates, which are listed here. I won't read them all out, but I'll give you a moment to look at them. Okay. So exclusion criteria included if the child was linked to multiple mothers, mothers who had hysterectomies before the end of the study, children whose mothers did not have an annual visit during the study period, children who did not have visits to primary care facilities, and children who would not or could not be linked to an address. So our final analytic sample was 52,919 mother-child pairs. And so our initial analysis included descriptive statistics to characterize the full sample by the mother's cervical cancer screening status. And we found that the average age of children in the study was 13, and about half of them identified as female. We also found that children of mothers who received cervical cancer screening were majority male, Hispanic, and living below 138% of the federal poverty line. And then for mothers, 63% of them received cervical cancer screening during the study period. And those mothers were more likely to have at least one chronic condition, more likely to be fully vaccinated against HPV, and to have had a preventive visit. Okay. So table 2 here is showing the unadjusted analysis, and you can see our results. This is from our manuscript that we submitted. And among all children, about 54% of them, I don't have like a way to do a pointer, but in the bottom corner, right corner, 54% of them had completed the HPV vaccine series. And then we can see that a higher proportion of children with mothers who received cervical cancer screening completed HPV vaccination. So 62% in that next column there. And then that's compared to children whose mothers did not receive cervical cancer screening, and only 40% of those children completed the HPV vaccine series. And so for our adjusted analysis, model 1, which I had mentioned before, SDI and child sex are both covariates. The This resulted in an adjusted odds ratio of 1.39 with a p less than 0.001, meaning that children whose mothers received cervical cancer screening were 39% more likely to have completed the HPV vaccine series than children whose mothers did not receive screening. I'll just let that sink in. All right. And then these are some forest plots, and I like forest plots because they're a really nice visual way to look at all these different stratifications. So this is showing our adjusted and stratified analysis. You can see here that we have it separated by female identifying children on the top half, yeah, in the green, and then male identifying children in the orange red color. And then it's also stratified by those SDI quartiles that I had mentioned. We can see that there's no difference in the odds ratios between SDI quartiles or between male and female children. And we know this because all of the confidence intervals or those bands that you're seeing are overlapping. So kind of to start wrapping up and going towards more of our kind of conclusions of the study, this study found a positive, significant association between a mother's receipt of cervical cancer screening and their child's HPV vaccine status. And this positive association was consistent across all SDI quartiles and for both male and female children. So there was no significant differences between odds of HPV vaccination in children experiencing higher degrees of social deprivation versus those with lower levels. And this might be due to the fact that our sample is derived from a community health center population, which serve predominantly low-income communities, and their levels of deprivation do not have a lot of variability. They're all relatively high. So that is that they don't really mirror national SDI patterns. And CHCs are also explicitly committed to providing equitable, culturally competent care to all patients. And my hope is this might explain why there is no difference in the measured association between SDI quartiles. And similarities in our measured association between sexes may be due to an increased efforts by CHCs and primary care providers to vaccinate male identifying children and adolescents. This kind of reflects a national trend in HPV vaccination rates among adolescent males that's increased faster than female rates between 2015 and 2020. So there's been a recent narrowing of the gap in HPV vaccination rates between male and female identifying adolescents. All right. So some of our limitations include that we were only able to measure cervical cancer screening and HPV vaccinations completed for linked parents and children seen in this OCEAN network of CHCs. So we couldn't really account for care that was received outside of the network or determine if some of the patients had left the network. So in the future, we might consider studies that merge data sets from other CHC networks and other places like OCHAN that are doing similar work and have similar access to data. And then we also acknowledge that we can't determine the exact relationship using emergency contact fields between the parent or mother and child, and differentiating between biological parent and other types of caregivers might yield different measures of association. The association between maternal cervical cancer screening and child HPV vaccination status might actually be stronger between biological mothers and children, possibly due to the fact that genetic susceptibility or a history of cervical cancer in the family may influence prevention behaviors. But in terms of our strengths, I think the strengths of this study include that it was the first study in the US to report these findings and include both male and female children. There was a prior study in England that found a similar association between a daughter's initiation and completion of HPV vaccination and the mother's receipt of cervical cancer screening. They found that daughters were more likely to have initiated vaccination and completed the course if their mothers had attended screening. And this was strongest when mothers had attended screening within the last 5 years. So their odds ratio was 3.5, 3.5 times more likely. And I like that this study kind of specifically included the timing of cervical cancer screening rather than just like at any point during the study period, which is how we had set ours up. But I will say that our findings, oh, I think I wanted to go here. Oh no, I want to stay here. Oh no, I wanted to go here. Sorry. Our findings emphasize kind of the multi-generational impact of cervical cancer screening and why multi-generational efforts to increase vaccination rates are critically important. So while the exact mechanism for our association is unknown, we think that it's likely that programs to encourage cervical cancer screening increase awareness among mothers about the risks associated with cervical cancer and HPV and encourage them to get their children vaccinated against HPV. It's also possible that mothers that prioritize preventive services for themselves also prioritize services for their children. And so another way to improve rates of HPV vaccination among children is to target attention towards increasing cervical cancer screening rates among mothers. And we can focus our resources and efforts on care of both mothers and their children. And that might be more worthwhile than isolated efforts targeting adolescent HPV vaccination. So, for example, this could look like coupling preventive visits for parents and children together, like if they are seen at the same clinic, or offering to schedule a child's HPV vaccination at a parent's annual exam. And then additionally, I think on from a larger perspective, population health perspective, community health centers are pretty much the perfect location and context to spearhead these efforts. And we should really work, on a broader policy level to really make sure that community health centers have the resources and education they need to provide counseling and outreach on the HPV vaccine, and especially to those who might have limited access to care or not seek care at all. All right, so I think I might have been fast because I talk kind of fast, but I also just wanted to acknowledge the data that we use, which came from this advance network and the OCHIN network, and then some of our funding, and then also just shout out our research team. I was just a very small part of it. There was so many people involved that were, doing statistical analysis and oversight and editing for all of this work. So just wanted to say a special thank you to all of them. And I think Dr. DeVoe is on the call, who is kind of the leader of our research team and of this research project that's been going on. So yes, I want to just say thank you. I also have all of my references in here if anyone wants to look at them. And I think I can take any questions.
And thank you, Anna Bloom, for that fantastic presentation. And thank you to everyone who attended today's session. Please be sure to find out more about this research by going to bridgetoinnovation.org. That's bridgetoinnovation.org. And please be sure to follow OCHIN on Instagram at @OCHIN Network. That's the @ OCHIN Network, and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And Don't forget to visit our Ocean YouTube channel to catch up on those past Grand Rounds presentations. And Ocean Grand Rounds will be taking off December for the holiday season, but we will be back on January 18th, 2024, where, in honor of Cervical Health Awareness Month, we will be welcoming Dr. Patricia Carney of Oregon Health and Science University as she presents on the results of the Rural Adolescent Vaccine Enterprise, also known as RAVE, project. Invitations to this presentation will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ocean.org. That's grand rounds, all one word, grandrounds@ocean.org. So from all of us at Ocean and Anna Bloom and Dr. Jennifer DeVoe to all of you, have a wonderful rest of your day, a great holiday season, and stay healthy out there.